Thank you for asking me to talk on elbow instability. I'm going to be giving you an overview of elbow instability and then discussing a simple elbow instability. Welcome to join us for our teaching on cambridgeorthopedics.com. Follow the links from the website. Thursday mornings at 7:30, lunchtimes on a Thursday, and then 15-minute Friday, where it's a didactic lecture, surgical approach or technique. So when it comes to elbow instability, this is Skater Boy. He falls and his hand is supinated and he has a valgus force put across his elbow, but he drags his elbow behind him. And we see the classic posterior lateral dislocation with the dimpling on the lateral side. Wrestler Boy puts his hand out in supination again, pops his medial collateral ligament as he puts a valgus force and axial load, but he manages to flick his arm free and escape. Weightlifting, think about what is the position of the hand. And so in this situation, the hand is in pronation. There's definitely an axial load and a valgus force. And surprise, surprise, he ruptures his medial dislocates laterally. This is Rhonda Rousey. She's the arm collector. She learned how to dislocate elbows, I'm sure, from Shawn O'Driscoll. Places the elbow into a hyperextension, places a slight axial load, and it's mostly rotation of the forearm, hyperextends her hips a little, and rotates the radial head off the back of the capitellum. I don't think she ruptures her medial collateral ligament here. I think she pivots around on the medial collateral ligament, and so this is classic PLRI or posterior lateral rotatory instability, ultimately all ending up at the same place with the dislocation of the elbow. Schreiber did a video analysis in 2013 looking at elbow dislocations and suggested that most of them happen with a valgus force. Now, this is how elbow dislocations happen that get videoed. And you'll see that you get videoed when you're wrestling someone, when you're skateboarding, when you're doing martial arts. So this is not how all dislocations happen. First point I'd like to make regarding this study. And I'd certainly agree with Shawn O'Driscoll's description of his title, Elbow Subluxation, the Spectrum of Instability in 1992, is a very big and wide spectrum of elbow instability. He suggested his horicycle back then that it starts on the lateral side and then progresses across to the medial side. And he talked about the reduced, the PLRI, the perched, and then the dislocated elbow. Schreiber suggested that everything starts on the medial side with a valgus force, with rupture of the medial collateral ligament progressing laterally. And I guess it differs whether you wrestling, weightlifting, whether your arm will be in pronation or supination. Now, they went on to suggest in this MRI study of 2014 that everything starts on the medial side. And for a while, there was a wind of opinion that the elbows now started on the medial side. Now, this was not a consecutive series of MRIs of elbows that had dislocated. This was, they looked at their MRI of elbow following instability and then assessed the injury. So a simple PLRI that pops back, that doesn't have a massive medial soft tissue injury, that is stable, that just gets moving, normally doesn't get an MRI. So they were selecting those that were either of competitive nature, so the wrestlers, weightlifters, or those who had quite a significant injury, particularly if it happens to the medial side. To rupture your medial collateral, put a lot of force through it. And so they looked at 16 sequential, not 16 sequential elbow dislocations. And they showed that quite a lot of the time the injury was on the medial side. I don't think it really matters. Does it start on the medial side? Does it start on the lateral side? At the end of the day, you end up with a dislocation. And it's important to bear in mind that the way you treat a dislocation is get the elbow moving. It's a little counterintuitive. Most times, if you've dislocated or if you've got instability, you may be tempted to immobilize that elbow and hope that by immobilizing, they'll end up with a better outcome. Duckworth's paper of 2008 showed that residual subluxation of the elbow from a simple dislocation and fracture dislocations treated with active elbow exercises and avoidance of various stress if you abduct your elbow or abduct your shoulder, you put a varus stress across your elbow. And what he showed, that you could get good looking x-rays and good looking patients and functional patients without operating on them. So I've talked quite a bit, but there's certainly a spectrum of instability, and that spectrum starts with the first divide on whether it's a simple dislocation or a complex dislocation. And for me, the definition of a simple dislocation is one that has no bony injury, so a soft tissue injury, and one that is stable to within the last 30 degrees of extension. Because if that elbow is stable and congruent to within the last 30 degrees of extension, it's normally stable enough to get moving. Plug into Duckworth's algorithm, avoidance of varus stress, so don't abduct the shoulder. Most times then, that elbow will do well with non-operative treatment. The complex instability falls into 4 categories then. The severe soft tissue, that one where you've ripped all of the ligaments, but not just the ligaments, it's often an association of the muscles, so the common flexor or common extensor origins, and those elbows are not stable to within the last 30 degrees of extension, and they require some form of surgical intervention to make them stable, to get them moving. Because you really do need to let the trip switch happen in your brain, that the treatment for elbow instability is movement. And what you need to do is get them to a position or a situation where they are stable enough to be safe enough to get moving. The other sort of spectrum of elbow instability, which will be touched on later by the next speaker, is the posterior dislocation with the radial head fracture and coronoid fracture. That's the terrible triad. The posterior medial rotatory instability, or PMRI, slightly difficult concept to get your head around sometimes. That's where the forearm rotates. You get an injury to the lateral side, the lateral collateral ligament complex, including the common extensor origin, and then a push off often of the anteromedial coronoid. That's Wrestler Boy, the second patient. If he didn't manage to get his arm out from behind him and got trapped with his arm behind his back, they are the patients who then generally develop PMRI. They have that varus force placed across their elbow. And then the proximal ulnar fracture dislocations, which can be divided into the transolecranon fracture dislocations and the Monteggia variants. I'm going to be focusing now on this group, the spectrum of elbow instability within the simple dislocations, and touch a little bit on the severe soft tissue dislocations. Now, what you're trying to decide now is this elbow stable enough to get moving, or do I need to do something to get it moving? Now, for me, the gold standard is screening the elbow coming to extension. Is it congruent and reduced to within 30 degrees of extension? If it is, it's stable enough to get to moving. If it's not, then I need to do something to the soft tissues to get it to that point. So ultimately, the best would be an EUA, and I'd put the A in small letters because it's a examination under anesthetic, but I'll sometimes do it in theaters without the anesthetic, so that I'm prepared if they do dislocate to go on to then stabilize the elbow, so it's not such a traumatic event. So I'll start with the elbow reduced, flex the elbow 30 degrees to unlock the olecranon, and then place a varus force across the elbow, testing the lateral collateral ligament and the common extensor origin. I'll place a valgus force across the elbow, and the problem here is that the arm is in supination. And if the arm is in supination, if you rotate the radial head off the back of the capitellum, what could look like clinically as medial laxity is actually PLRI. You would see it on the x-ray if you were screening them, but you're better off pronating the forearm, locking the radial head onto the capitellum, and then placing your valgus force. And here we see in the top right picture variations of injury to the medial collateral ligament. And so that I would suggest would be normal. That image there would be rupture of the medial collateral ligament, but the common flex origin is still intact. And there they've ruptured the medial collateral ligament and the common flex origin, a much more significant medial structures of this elbow. And here the force is continued from medial to lateral, and involving now the lateral collateral ligament and the common extensor origin. And this is the bald humerus. You'll find that there's absolutely nothing attached to this humerus. This definitely is complex soft tissue instability. This needs something doing before it's stable enough to get going. That likely needs something doing to make it stable enough to get it moving. That, although there is an injury to the medial collateral ligament, might actually still be stable within 30 degrees of extension, which means unless they really need a strong medial elbow, javelin throwers, goalkeepers who continue stopping balls, people who do a lot of weight bearing on their upper limbs, most people, if you've just ruptured your MCL, don't need surgery. But what I really want to know is this elbow stable and congruent to within 30 degrees of extension? Now, if you stay in this plane and twist the arm, you will twist the elbow out. And so swing your image intensifier around so that you get a true lateral of the elbow. Make sure that the elbow is reduced. Flex it to 90 degrees. Get your condyles and ulnar humeral joint nice and crisp. And then what you want to do is gradually extend that elbow. And you want to get to that point where you see that ulnar humeral and radiocapitellar joint are reduced and congruent. You can go on to do the hanging arm sign if you really want. I don't always test my fixation to that level. But if I see how that elbow has come through from 90 to full extension, nice and congruent, I know that that elbow is now stable enough to get moving. They don't need a cast. They don't need a splint. They don't need a brace. They can simply get their elbow moving. So the gold standard, I would say, would be the EUA. Other ways to assess the soft tissue injury is to look at your initial radiographs. Look at the distance of this radial head to the capitellum. She's certainly ripped her her lateral collateral ligament and her common extensor origin. You don't need an MRI to see that. There's no way that forearm got there without tearing off everything from the distal humerus. The ulnar is not in the same postcode as the trochlea. It's shifted posteriorly and laterally. And so certainly she's injured her medial collateral ligament and likely her common flex origin, because the medial epicondyle is sitting all the way up here. This humerus is sitting just under the skin, just the neurovascular structures between her distal humerus and the skin. And so this will be the bald distal humerus. This is going to be a very unstable elbow. There's her first post-reduction films. I see a small but inconsequential fracture of the radial head. And I see on her first films that there's some laxity of that lateral side. Medial side looks good, ulnar humeral joint looks good. But I'm worried, and I'm really worried because of the initial displacement. Sadly, she gets discharged from day 0, which is the worst thing you could have done because the elbow is stupid. It has poor proprioception and not a lot of pain fibers. And when she pitches up at 7 months, you only salvage really an 8-year-old at this stage is a total elbow placement. So although you think it may be simple, on your x-rays, I would advise you to x-ray them. Sometimes I'll x-ray the weekly for the first 3 weeks if I'm a little bit worried. Well, I'll certainly x-ray them week 1 and week 6, because what looks simple, sometimes not simple. In retrospect, in her initial imaging, this was never going to be a simple dislocation. I see a 32-year-old with a posterior dislocation, and it all looks a little bit odd. But the forearm is still fairly opposed to the humerus. And have you seen this picture before? Do you recognize it? Yes, this is Sean Driscoll's PLRI, or the perched one. What's happened here is Ronda Rousey has supinated this forearm and twisted the radial head off the back of the capitellum. You can see that on the AP. But the medial collateral ligament is still intact. The force has just started on the lateral side, got to anterior capsule, but hasn't gone all the way across to the front. And so when that one pops back, likelihood this elbow is going to be stable enough to simply get moving, but I'm going to avoid the varus stress and plug him or her into Duckworth's protocol. 24-year-old posterior lateral dislocation. So this could be skater boy. Although it's posterior lateral and may have been PLRI, it may have started off as a varus valgus force across his elbow and gone across from medial to lateral. Or did he start lateral and go all the way across to medial? In fact, it's irrelevant where he started. This is where he is now. Now, he's perched or dislocated. I would say he's dislocated, so stage 3. So I would worry about this one a little. And in a 24-year-old, I would have a look at the soft tissues. I look at the first post-reduction images, and the elbow is beautifully reduced. There's no drop sign. They're in the back slab, which is adding extra weight to this forearm, but it's still beautifully reduced. So I'll examine them in clinic, take a first x-ray. It's beautifully congruent. And if they're comfortable, I would get them moving. If there's not too much swelling on the medial side, which there isn't, so maybe this was a PLRI, medial, lateral to medial, as opposed to a medial to lateral, I might be tempted to just get you moving, but I would x-ray you again in a week's time, because the elbow is stupid. It's got very little proprioception and not a lot of pain fibers. And what you don't want is someone to pitch up with a dislocation at 6 weeks. I would x-ray them again at 6 weeks. And unfortunately, this person was a bone former. They got moving right at the beginning, but you already see the HO forming at week 5. I won't get distracted by that for the rest of this talk, though. We now see a 40-year-old again with a posterior lateral dislocation. It's dislocated, but that humerus is further down the forearm, and that humerus is not well applied to my ulna. So the soft tissues, I'm worried a little bit more about this one. And when I do my x-ray in the back slab or post-reduction film, I see that drop sign. I see how the humerus is disassociating from my forearm. And that's the problem with back slabs, is they just add a little bit of weight. And if you add enough weight and a little bit of rotation, you will clear your coronoid and you will dislocate again. So this worries me a little. And so this is the one where I'm thinking, maybe I need to take you for examination under anesthesia. I need to see whether you're stable and congruent to within 30 degrees of extension. And I'll take them to theater and I would do it awake. And if they're awake and everything goes well and it's nice and stable and congruent, I'll get you moving. I don't really want to know if the MCL or lateral collateral ligament is injured. It's interesting and I'll document it. But I want to know, are you stable to within 30 degrees of extension? Because if you are, you're stable enough to simply get you moving. X-rays of a 32-year-old male, and it's an interesting pattern. I'll give you a second to look at it and think about it. It's a posterior medial dislocation. Now, it's important to bear in mind here, my choice of words, posterior medial dislocation, not posterior medial rotatory instability, not PMRI, but posterior medial dislocation. So I look at this and I think, what's been injured? Well, lateral collateral ligament, almost certainly. Lateral ulnar collateral ligament. There's no way that stretched all the way from the center of the capitellum to the supinator crest. But in fact, MCL might be intact. Reduced in ED, they said they reduced it and it popped out. Well, maybe they just didn't reduce